right, we are going to begin. It's the top of the hour at our May 27th Gravity Public Call. I'm Sarah DeSilvi. I'm the Director of Terminology for the Gravity Project. We have an action-packed agenda today. We may utilize the full hour and a half that we allot ourselves for this meeting in order to cover what we have to address, and we welcome all of you to the call. Next slide, please. As always, just a few meeting topics and approaches. So due to the large number of attendees, they start rolling in over the next few minutes. All participants are muted upon entry. We ask that you remain muted throughout the meeting to avoid background noise. The call is always recorded, and recordings are uploaded to the Gravity Confluence page following for review. You're encouraged to participate in the discussion by using the WebEx chat if you send them to everybody. I do work the chat to, Tom is asking whether anyone else lost audio. Okay, thank you, Ron. You're encouraged to actively participate in the discussion using the WebEx chat. Again, I try to work the chat and make sure everyone's thoughts are included in the conversation. Please send chats to everyone. Please try to refrain from sending chats just to me if you want to keep them between you and I, or it's not part of the public conversation, because it's very difficult for me to filter that out as I'm leading the meeting. Next slide, please. This is just a classic antitrust practices slide. Next slide, please. We always invite everyone who might be visiting to officially join the project. Every one of the links that we're presenting should be flowing into the chat over time, so you can follow the hyperlink if you wish from the presentation. If you want to check whether or not you've already signed up, or you can always follow the Confluence link there as well. And then the Confluence in general is just a riot of information regarding past and current initiatives. So you can always find information on the Confluence there. Next slide, please. A very quick shout out to all of our project funders, grantors, and in-kind supporters. Very, very grateful. It looks like Evelyn is having some difficulty getting on the WebEx. So if anyone else is having difficulty, please email us and we'll try to figure out any barriers. We do, many of us are on, so it must be, sometimes they have flow issues with WebEx where they don't let everybody on in time. Next slide, please. So this is our agenda. It's quite full. First of all, we're going to be running through some announcements very briefly. There's one big one to announce. We'll go through the project schedule and overview. And then this is a different type of meeting today. It's really a chance for our incredible subject matter experts to bring some of the perspectives on considering the domain to you all, so you can understand the terminology that will be blooming in the masters over the course of the next weeks. So we have various presentations. So we have perspectives on intimate partner violence screening and diagnoses, both considerations from Fenway bringing the LGBTQIA perspective, and then Lisa from Futures Without Violence is presenting the Q's approach. I do want to highlight something that Lisa will be talking about, which are kind of the limitations of, classic screening questions and answers methodology, as we see in many of the submitted tools we have so far. You'll see that theme of the limitations of screening questions and answers carried into some of our considerations on elder abuse, when Dr. Rana Cierno is just talking briefly about what's called the behavioral approach, just so you can understand when you see this and you see some of the decisions we're making when they're presented to the community. After that, we'll be going into social isolation, screening, and diagnoses, really discussing social connection, different subtypes. For those of you who have been on previous meetings, you know that we kind of initially identified addressing social isolation and then carved out loneliness, and really to address the breadth of the concerns of social connection. There's really 3 different subtypes you'll be seeing and we'll be discussing today. And each of those different subtypes will have kind of a general best screening methodology and diagnostic output. And Dr. Matt Pantel from UCSF is going to be talking about those 3 definitions of social isolation, loneliness, and lack of social support briefly with us today. And then we'll be going into elder abuse. The elder abuse domain is really kind of raising the bar for gravity. There's just way more research and best practices in elder abuse than there are in some of our other domains. So we are having to raise our own bar, which includes assuring we have accurate validity documentation for the screeners that we are including. And so I did ask Dr. Ciarno, Ron, to come and talk today about the behavioral approach. You really should find some similar themes between this, as I mentioned, and the cues approach. So really just, it's really just considerations of how to elicit trust-based information from individuals in order to get accurate screenings for intimate partner violence and elder abuse. Mark's going to do a brief policy update, then Bob's the technology update, and then community homework's the next step. So really this is a bringing the subject matter experts to you all day to day across all of our domains. Next slide, please. Announcements, next slide. This is always our announcement regarding seeking sponsorship. If you wish to sponsor, you can always follow the link on the Confluence. You saw many of our sponsors on the slide prior. Next slide, please. This is the big update first. We are ever so excited to announce that we just found out on Tuesday that 10 CM or really economic-driven social risks that we worked on over the course of our inaugural year have been approved by the CDC and will be in the ecosystem in October. So this is pretty exciting. So this includes a limited set. It's not everything we asked for in March, but it does include the following diagnoses, which is less than a high school diploma, which is a missing diagnoses within the education domain. It includes the return, as we ask for, the Z58 series, which is problems related to physical environment, which allows us to specifically identify inadequate drinking water supply. We talked about this being really significant in the Flint, Michigan use case. It does allow for stratification of different types of homelessness. We worked on this very closely with our homelessness experts. It allows for specific diagnoses for food insecurity, which stems from now the former lack of adequate food and safe drinking water. It allows for the important, completely missing set of diagnoses of housing instability, which carry very specific risk. So all of the codes you see here. So this is an incredible piece of work. It was a large effort on behalf of the Gravity community, everyone writing letters. So these are coming into the ecosystem October 2021. And then please remind who approves changes to ICD-10. So the process for ICD-10 CM approval goes through a committee within the CDC. So it's the CDC National Committee for Health Statistics, ICD-10 Coordination and Maintenance Committee meeting. They're responsible for maintaining the extension of ICD-10 CM that ICD-10 that we take from the World Health Organization. So in order to have these codes approved, we had to present it to that division of the committee of the CDC. It had to be vetted by a national open meeting, national comment period, and here we are. I'm sorry. Pastor just had a really hilarious comment. That's great. Next slide, please. And really, just congratulations, everyone. I mean, I have to admit, I got a little emotional. We first submitted Food Insecurity Code about 5 years ago, so it's been a long time coming. We do want to mention that there is another code that's on target already without any changes to the October 2022 release. Remember, there are these yearly cycles of release, so if we miss one, we have to wait for a whole another yearly cycle. And that was the Encounter for Counseling for Socioeconomic Factors code. There are a set of codes that have been assessed by the committee as needing a little bit of further refinement. We do not know what the concerns are yet, but we are scheduled to bring them back to the September 2021 ICD-10 Coordination and Maintenance Committee meeting, and they are projecting, with the slight alterations, they will be released in October 2022. So these include our concepts for veteran status, transportation insecurity, financial insecurity, and material hardship. Woo! Very interesting. Hi. Yes, Lucy. Hi.
Can EHR designers enable or allow users of their EHRs use the codes that Gravity recommends before they are approved for ICD-10?
Not,
Yes.
well, yes and no. Evelyn's piping in. Evelyn, what was your thought there?
No, I would say vendors, they can update their platforms to incorporate the new codes. What is pending? So on their end, they may have to if the SDOH data class is included in US CDI and they are a certified technology, then they would have to abide by what's required there for certification, but that won't happen until certification deadline comes into play. But right now they are able to incorporate these codes as needed if they know, especially if they know that they're coming. The challenge is always on payment, right? So they will only be incentivized to include them if they, if their customers are asking for them, or there's a way for the providers they support to be paid for documenting that information. And right now there is no incentives in place or payment tied to the ICD-10 Z code entries, but many do incorporate Z codes, in particular for quality reporting. So if they're part of payment models, they use the data. So just want to acknowledge there is no specific requirement for the EHR vendors to do so, but this will make it easier for them to know what's coming down the pike.
Well, I think it's actually quite complicated. I don't want to make it too complicated, but we do know that the E&M coding updates did allow for inclusion of social risk as part of medical decision-making complexity. So even though there's not a classic, reimbursement for a Z code, being able to demonstrate specifically that food insecurity was a consideration in a diabetic's inability to control their A1C and required specific interventions, so that you're allowed within the new E&M coding guidelines to include social risk as part of medical decision making in complexity. So that use case exists right now. The only thing I would also add, Lucy, because this is what I thought you were asking, is there might be changes to the code that hasn't been released yet. So I would say the codes that we have clearly highlighted for either October 1st, 2021 or October 1st, 2022, those can be, by any agreement, can be starting to be utilized in the ecosystem. It's just the one I wouldn't venture to use the ones we submitted but haven't been fully refined.
This is Bob. Let me add a little color to that. Typically, the EHR vendors will only take the standard release from a code system and incorporate in the EHR. They especially will not do anything else if whoever is going to receive it may reject the transaction because they themselves have not supported it. So if they're going to include an ICD-10 code as part of a billing transaction and that payer doesn't recognize it because they themselves have not chosen to update, then they'll reject the claim, which is the last thing they want them to do. So there's some other pieces here. The safest thing for everybody is wait until the release occurs, and then everybody is pretty much obligated to take the release.
That's terrific, Bob. I was thinking it would be so helpful, at least for some people. There's over 100 of us on this call. If EMI, along with whatever expertise would be needed, could make a matrix of the codes that we're recommending, what their status is, when we expect them to become official, by whom, and the challengers and barriers to implementation prior to October 2021 or October 2022. That's where our rubber hits the road. We can talk till we're blue in the face how wonderful it would be if people would understand the social determinants and document them as we are recommending. But if the EHR doesn't allow it, and as Bob has just indicated, if interoperability isn't up to it, then we're waiting who knows how long. So some kind of what has to be done matrix by whom would be so useful, in my humble opinion.
Lucy, we are definitely hearing, I think one theme that's across the Gravity ecosystem is we have enough deliverables out there that we need to start being really clear about how to assist with implementation, right? So we've already talked with our colleagues at UCSF Siren regarding, webinars to that effect. So just know that this is it's a brief hooray with a lot of work in order to make sure that our community is ready to receive and advocate and implement these codes with understandings of the timelines involved.
You're way ahead of me. I'm thrilled. I'm so glad I asked the question. Thank you.
Of course, Lucy, you always ask the best questions. Not the best, you're very good. And so I hope any other questions regarding this. This is a huge, just a really exciting moment for the Gravity team, and meaning all of you. When I say the Gravity team, I mean all of you. All right. Okay, next. So look more to the implementation guidance and webinars and documents, and coming soon to resources near you. Next slide, please. This is kind of a announcement package in order to get through to the work to be done for the day. So announcing the HL7 Fire ID public meetings Wednesdays 3 to 4, announcing that the HIMSS SDOH guide was published, announcing that there's an ONC webinar on advancing SDOH interoperability on June 2nd. They wanted to announce that there's a provider payer data exchange initiative on June 3rd. This is all available on the Gravity announcements. We realize that we've been spending a fair bit of time doing announcements in the meeting, but we need to get to content, so we're trying to move through. Next slide, please. Next slide, please. All right, so this is just our roadmap. There is a very nice arrow pointing to the CMS Connect-a-thon and the road ahead. So individuals just can get ready for that. I believe Bob will talk more about that. But here we are in the end of May, working through social isolation, intimate partner violence, and elder abuse. Next slide, please. Again, I'm not going to go through these slides. These are just the terminology engagement guides, which basically talk about the interplay between subject matter experts and the public calls. And next slide is important. If we're addressing any domains that's a past domain, please just we'll route you to the section on the Confluence where we've addressed that domain in the past. And then if you can email us, so that way we can make sure we're addressing current topics right now, and we're free and welcome to catch people up after the meeting or through email if necessary. Tom is already discussing implementation. Tom, you're always ahead of the game. All right, next slide, please. Next slide. And next slide. All right, so this is just a trimmed down version of the terminology roadmap. Next slide. Thank you, Greg, for the link to the ONC Advancing SDOH Interoperability webinar. So we wanted to report that we've reached consensus on the stress voting results. We want to thank you, everybody, for voting. We did have a few updates. So every single time you vote yes with a comment, those comments are taken back and integrated, and we hear them. So there were really two very on-point comments about too much space between some of our diagnostic comments we included in the set and the definition we proposed. This is both from our colleague, Dr. Monique Van Bergen from the AMA and Michelle Prozer. So because of this, we went back to the subject matter experts to refine the diagnoses in the set. Next slide, please. You can see this here. So given that our baseline definition is stress occurs when a person perceives the demands of an environmental stimuli to be greater than their ability to meet, mitigate, or alter those demands, we really just kind of trimmed down things that felt too vague or that had other variables that weren't contained in the initial definition, or were really just not met by the screening methodology we had included in our screening questions and answers set. We just became a little bit more rigorous. So you can see on the left-hand side are the codes that really were best matched, again, to the screening methodology and the definition that we have. And these really mirror the comments of our two colleagues. So this is just being very barefaced. So when individuals make comments, we do try to refine and then return this to the community. If anybody has specific concerns regarding this, please just send us an email. We're not going to talk about it right now because we do have a really huge agenda, and I want to respect the time of our subject matter experts who are on the call.
Sarah, we need to be grammatically correct. Demands of an environmental stimulus or demands of environmental stimuli. One or the other, please.
Thank you. Lucy,
Okay.
I love this about you. I remember when you did this about strata and stratum too. Thank you so much. We will make sure that we correct it. I love it.
Bye.
Yeah. Noted. Next slide, please. All right, so here we are. So you can see that we have pushed off our social isolation and elder abuse consensus votes because we're doing a lot of work. We want to make sure we get these masters right before you vote on them. And there's been a lot of sorting that you'll hear about today in order to get the information to you on the master. So we're here 527. We're just reviewing all kinds of topics. And then we'll not be voting until 6:24. This pushes our vote for elder abuse off a little bit. I did propose to the subject matter experts whether even that was appropriate because, again, they're raising the bar with us and really want to ensure that the screening approaches that are in the set have good psychometrics and validation behind them. So in order to do our due diligence, that might take a bit of time, but this is where we are right now. So here we're just going to be talking about really considerations across social isolation, intimate partner violence, and elder abuse today with representations from our subject matter experts. Next slide, please. Any questions? All right. Next slide, please. Okay, next slide. Here we are. We're just identifying all kinds of concepts. So, and next slide. These individuals are representative really of communities that come behind them. So SMEs are actively reviewing the initial master. And so we have all the concepts that we've gleaned from initial screeners and diagnoses, and we're going through them. So next steps are we continue to meet weekly or every other week at least with our subject matter experts. And so our SMEs are Chris Grasso from Family Health and Lisa James from Futures Without Violence. So we have a set of two different presentations. First, we really want to elevate the perspective of Fenway, given their expertise in this domain on LGBTQIA perspectives on IPV. And then Lisa's going to talk about the CUES approach to screening for really preventative action for intimate partner violence, which again, I want you to draw themes to some of the limitations in the elder abuse screeners and what Ron Sierno will be talking about very shortly with elder abuse. So I believe that we have slides to switch. So next slide, I think next slide is Lisa James. Lisa, are you ready to present?
Yes, I thought Chris was going first, but I am definitely ready.
Oh, sorry.
No worries. You can hear me okay?
Chris, do you want to go first? Or?
Yeah, sure. If that's up to you. Lauren is with us. Does she have the ability to share her screen? I think she has some slides, but
yeah, absolutely. So so sorry, Lisa, just for the sake of what I promised happening, you're very kind.
No worries.
So Sarah B, can we pass the to Fenway so they can present?
if you could pass it over to Lauren, that'd be great. So I could, as Lauren is on video here, I could just introduce her. One of the many things I love about working at Fenway is that I get to work with some very knowledgeable and talented and experienced colleagues. And so Lauren Curvis is joining us today. She's the manager of our violence recovery program at Fenway and has lots of valuable experience in the space talking around IPV, in particular the intersection with the LGBTQIA community. And so she's going to share some of that information with us today. So Lauren, I will turn it over to you. Thanks for joining us. I appreciate it.
Yeah, absolutely. Thank you all so much for having me. Can I get, Chris, I can see you. Can I get a thumbs up that you can hear me?
I can,
okay.
Yeah, I can hear you out. Thank you.
All right, awesome. I'm also going to try, I have a few slides, so I'm going to see if I can share them. I'm super new to this WebEx format, so I finally, like a year in, got the hang of Zoom. All right, so let's see if I can figure this out. Oh. Is that?
It's all perfect. Yep, we are.
Amazing. I'm so happy. Okay. So let's see if I can do the slideshow option. Okay, and we're seeing that too?
Yes, we are. Carry on. Good job.
Okay. Great. So I will just introduce myself. Like Chris said, I'm the manager of our violence recovery program at Fenway. So we specialize in working with LGBTQ survivors of intimate partner violence. We also do work with LGBTQ survivors of sexual violence, as well as anti-LGBTQ hate violence and police misconduct. We are situated within Fenway, but we work with specifically Fenway patients, but also we take outside referrals because of the kind of specialized services that we offer. We don't want to just kind of limit to folks who are only patients of Fenway Health. And some of those services we offer, just for you all to know, are that we're grant funded, so we're able to offer free non-insurance billed services for our survivors. And that includes counseling with licensed clinicians, as well as advocacy, kind of case management type services. And we also do like groups and then education in the community as well. And one of the big functions that we do that I always think is interesting for folks is that we help write mental health evaluations for folks who are seeking asylum based on their LGBTQ identity, so having experienced abuse in their country of origin. But the biggest portion of what we do is work with survivors of intimate partner violence. I've been in the domestic violence field for my whole social work career, about 12 years. And so it's also really nice to like interact with other people in different spaces, kind of outside of the like the domestic violence world, so to speak. So just to set the stage a little bit, I'll try to be brief, but we're talking about intimate partner violence and domestic violence. We're often the kind of narrative and mainstream perspective is this cisgender heterosexual female as the victim survivor, and then cisgender, meaning non-trans, not non-binary, heterosexual man as the abusive person. And although that is a very common dynamic in domestic violence, lots of those folks, that is the identity of a lot of the folks that other service providers work with. We sort of think about what's left out of that narrative. And so even like when I got started in working in shelters, the shelter that I worked at, I used to work in Colorado. We didn't accept anybody that wasn't female. And then we moved at some point to accept folks who were also trans women, thinking that we were being really progressive, but still who was being left out of that conversation were anybody who wasn't anybody who didn't identify as female was kind of left out of that. And that's part of what we bring to the services that we offer, is just really acknowledging and owning that LGBTQ folks experience intimate partner violence. So I'm going to go in a little bit to just some of the data, just to get a sense of a little bit of this kind of, how prevalent is this? So, and I will acknowledge that the research and data on this is not as prolific as we would like. So some of the information that we're getting is from 2010, 2015, that sort of thing. So hopefully we'll have more updated numbers at some point. But so in 2015, the UCLA Williams Institute surveyed the literature going back all the way to 1989, and found that LGBTQ individuals experience intimate partner violence at similar or higher rates than that of their straight cisgender counterparts. And then the data, time and time again, has shown that folks who identify as bisexual and or transgender individuals are at higher risk, so their numbers are often a lot higher. So this is from also part of that Williams Institute survey. So just looking at some of the general population, we find that the numbers of bisexual men who've experienced at some point in their lifetime intimate partner violence are higher. Gay or lesbian men, sorry, gay men are comparable, lesbian women a lot higher. So those are some of the statistics that we're looking at in terms of prevalence. And then we just like to point out really the significance of how common this is for folks who identify as transgender and gender diverse. According to a 2015 US transgender survey that surveyed the whole United States, 54% of folks reported experiencing some form of intimate partner violence, including acts involving coercive control and physical harm in their lifetime. So those numbers are pretty high, and we're also always pretty assuming that these things are underreported. And then when we're looking at other, I don't have a ton of the data today, but when we're looking at a lot of other intersecting marginalized identities, such as trans women of color or folks who are undocumented and other kind of vulnerable identities, the numbers tend to increase. So kind of what makes LGBTQ specific abuse unique and domestic violence unique is that so there's a lot of similarities, right? We're still looking at power and control as the kind of overarching theme to the way that abuse exists in intimate partner violence. Somebody's still using power and control to kind of manipulate and abuse a partner. However, some of the unique pieces of that that we see time and time again with the survivors that we work with are specific aspects of somebody's sexual identity, somebody's gender identity being targeted as a means of the abuse. So I have some of the examples up here, but ultimately what we're talking about is, you know, somebody potentially threatening to out someone at their workplace, whether it's that they're trans or that they're gay or queer, intentionally using the wrong pronouns for their partner. Sometimes this looks like controlling the way that somebody expresses their gender identity. So maybe seeing, I work with a lot of folks, trans women married to cisgender men, who are really dictating the way that the trans woman expresses their femininity, right? And are sort of controlling, like, this is what it means to be a woman, and this is how you will perform womanhood. So we see that a lot. We see using biphobia as an excuse to kind of isolate bisexual survivors. So in a lesbian relationship, kind of using biphobia to control and victimize a female partner who might also, who is bisexual. Sometimes we see for transgender survivors and specific kinds of sexual abuse that are targeted at genitalia, that's usually aligned with a specific gender. So either at the chest or genitals, that sort of thing. It's kind of a lot of examples, but there's often another big piece that we see is LGBTQ communities tend to be small. There obviously isn't one overarching community, but a big aspect of a significant tactic in domestic violence is isolation. And so the way that this plays out a lot in an LGBTQ specific partner abuse is somebody further isolating somebody from their community, whether it's, bad mouthing them or kind of being controlling or abusive in, typically queer spaces, that kind of thing. There's a lot of ways that this can look that really lead to denying access. So in addition to kind of what makes LGBTQ abuse unique is then the access to services and kind of the barriers that folks are dealing with when they're then trying to reach out for help, right? So if they're going to their mainstream domestic violence agency, if they're going to police, if they're going to a community organization, a hospital, all of the different kinds of systems that people interact with, those are the places that they then may get met with homophobia or transphobia, or even just ignorance and lack of education and knowledge around the fact that they could be a survivor. So it might not even be intentional, but it might just be a cultural misunderstanding. I was actually speaking with somebody today who is a gay man, Brazilian, Portuguese speaking, and we have a Portuguese speaking domestic violence agency in Massachusetts, and he was talking about kind of experiencing some homophobia from that agency. And so there's just some ways that we sort of talked about. Is it cultural? Is it kind of a lack of education and awareness of the prevalence of LGBTQ intimate partner violence and the fact that a man can be a survivor? So those are kind of some of the things that we think about. So just a couple other pieces I'll mention. I think interesting statistics are the National Coalition of Anti-Violence Programs in 2009, again, over a decade ago, but did a survey and found that police are 10 to 15 times more likely to make a dual arrest in cases of same-sex intimate partner violence as compared to heterosexual ones. So then we think about sort of the trauma of a survivor going through the system, and this kind of dual arrest or dual restraining order type thing to happen. And so that's the other piece about the mutual restraining order is mutual restraining orders are more likely to be granted in same-sex or same-gender relationships. I have a few more slides just about kind of highlighting some of those unique obstacles, but I know I didn't have a ton of time, so I just wanted to make some of those main points and talk about, so we're looking at the ways in which the, society and culture perpetuates some of the stigma against LGBTQ survivors, and then the way that plays out in those relationships. And I think those are the two pieces that I felt like was the most important to highlight today, and some of the things that make the work that we do unique in terms of working with this population. And I've got a few, just some slides about best practice, which are pretty basic things, but just stuff about pronouns, really having education about the prevalence of LGBTQ survivors, what that looks like in intimate partner violence. This is a really good example, right, of what we're doing right now. It's just kind of getting some understanding and knowledge of the prevalence of this and kind of how it looks and plays out. And that's all I've got. Yeah, I don't know, Chris, if you want to add anything.
No, that was perfect. Thank you, Lauren. I don't know if Sarah, in terms of, did you want to jump next, Lisa, or how do you want to do this? But that's fantastic.
Yeah, so while Lisa gets her slides queued up, I just wanted to first of all thank, so it's actually, I think Linda's going to take back ownership, and then there's Lisa's slides. Yes, Lauren, I just wanted to actually elevate something that we've already found as a bias within the current terminology for diagnostic terminology. So it only took like one quick look for us to realize that there was really a binary approach to partner identification in current US ICD-10-CM, which is really like not able to represent whole vast swaths of populations, right, and people that we care for. We talk about in the Gravity Project that we really are addressing that first injustice of invisibility. And if you literally are not able to define yourself as a spouse, or define yourself, like if there's only binary gender options within ICD-10 perpetrator diagnoses, it's just not representing the truth. So I do want to elevate that. So before we segue, actually, it looks like there might be some questions. Lisa, are you okay taking a few minutes just to address questions?
Yes.
So just feel free to, we have Tom Page is asking if there's any data on whether bisexual people experience violence with same-sex or other sex partners differentially, or is there data on that?
I love that question because I think that it leaves out like kind of a significant part of the story when we're kind of looking at who are the people that are doing. Oftentimes the statistics are on the victims and survivors, and we're not really getting a sense of who is on the other side of it, right? And so I actually don't have that data. I imagine that it may exist in some of the studies that I was looking at. So I could definitely circle back on that, but I think that's a really good question with a really poignant point of kind of the significance of highlighting the person actually doing the perpetrating the abuse. So yeah, thank you for that question.
Lauren, I had a question for you. And
yeah, go ahead.
That this data would be very difficult to collect, but do you have any data on prejudice experience in the healthcare environments?
Yeah, I think I heard your question. It was very quiet. I think your question was specifically on data and statistics in healthcare environments. Are you asking specifically around like something similar to kind of what we shared with the like police arrests, like kind of how often either people are denied a service or something of that, something like that? Like, is there specific data, I guess?
Yeah, and I think that's extreme, denied service, but I worry that people should not even go to healthcare environments because they've experienced prejudice, you know, after being attacked.
Yeah. So yeah, something, I don't know if you all would be interested, but there's a really great, so the most up-to-date research I've seen is specifically in the state of Massachusetts. There was an organization that did a community needs assessment, and they put a lot of data in there, specifically it was only surveyed LGBTQ survivors of intimate partner violence. And there was a lot of data around like people, exactly what you're saying, people not accessing services, like the likelihood that people will actually take the step to go to a healthcare provider or report to police and that sort of thing. I don't have the specific numbers, but I know that it's definitely more will not enter those spaces than will make that report. And the overarching theme was that LGBTQ survivors seek out LGBTQ specific service providers, and so there's just like a really serious lack of that specialized service in the domestic violence community.
So just for the sake of time, I'm going to invite the Fenway folk to come back, as we always do. Well, you guys are always here because we do need to keep on moving, but I do want to just answer one specific thing from a terminology perspective. So Tom, identifying the perpetrator is a key part of the terminology gaps that I was just saying within ICD-10-CM for current documentation of LGBTQIA approaches to coding. So yes, so we do need to make sure we document perpetrators. The current gender options within ICD-10-CM are not inclusive, and part of what we'll do with our work is make sure that we address that. Lauren, thank you so much. And obviously, I feel like this is a necessary thing to ground our work within this domain. We do have a bunch more presentations, so I'm hoping to segue to Lisa so she can take us out with, really, this is an important consideration because switching to Lisa's presentation, because you'll see themes again on limitations of kind of the question and answer screening approach to identifying situations of abuse and violence. And those themes, again, will carry across our work in elder abuse that we'll talk about in a few minutes. So passing the mic to Lisa.
Thank you. And thank you, Lauren and Chris, for your work. Always appreciate your leadership in the field. And I think we'll see some common themes as well around reporting and some of the things I want to share as well. So next slide, please. You know, as we talked last time, we see some pretty significant policy shifts around intimate partner violence being recognized by the task force, and also a new UDS measures for IPV and human trafficking. Next slide, please. But we're still seeing, even after 20 plus years of screening for intimate partner violence, you know, a lot of lessons learned and a lot of challenges. And so I wanted to bring some of those to all of you because I think it has implications for the work that we're trying to do together. And one of the biggest challenges that we're finding is that even when delivered by the best provider, we're seeing very low disclosure rates compared to what we know the prevalence to be around intimate partner violence. So if you're looking at the prevalence of 1 in 4 and 1 in women and 1 in 9 men estimated survivors of intimate partner violence, but only an average of 7% disclosing in clinical settings, we know that there's something we're missing. And even in studies where we find that women, in this case, 21% of women and 5.6% of men had reported in the survey setting that they were survivors of domestic violence, but they did not report that to the healthcare professional. So low disclosure rates, and we see the same thing in home visiting as well. Next slide, please. And also sort of spotty implementation, as hard as we all work around getting the precise terminology right when it actually gets rolled out in the field. And these are just some experiences that we've seen from the field about how the screening questions are implemented. So things like, no one's hurting you at home, right? Sort of leading the question to be a no. And also not even necessarily looking at the patient while asking the question. Or, I'm really sorry I have to ask these questions. It's a requirement of our clinic. And so, again, these are just some common challenges that we see in terms of implementation, but they have implications for how we recommend practice changes in the future. Next slide, please. Looks like it needs another enter. Next slide, please. In thinking about not only, thank you, what does the provider do, but also why might a survivor not disclose intimate partner violence and also human trafficking as well when asked? And there's a whole host of very good and valid reasons why somebody might choose not to disclose. And these are just reflected in the research. And one I think that we're really learning more and more about is around the issue of reporting. And Lauren touched on that as well. Definitely there's shame and as well as legitimate fear of retaliation if the person who's using violence finds out that there was a disclosure, but also a very legitimate fear of reporting and particularly fear of your kids might be taken away from you if there are reports made to Child Protective Services. So these are just a whole host of reasons why folks might not disclose. Next slide, please. And the National Hotline on Domestic Violence conducted a focus survey of some of their callers around their concerns or around the issue of reporting and police involvement and Child Protective Services as well. And 60% of the participants said that they fear that their fear of reporting changed what they decided to share with the healthcare provider. And you see some of the quotes here that are really just devastating to those of us who are trying to improve the health services to survivors and promote prevention. But folks are saying that once they realized that there was limits to confidentiality, they stopped going to their doctor's office. They just kept everything to themselves. And now I talk to no one. There's no one that I can trust, no one I can turn to, and no one where I can go. So obviously we're working to change that. Next slide, please. And think through what changes in practice we might want to promote to make folks feel less isolated. And similarly, healthcare providers are confused because the reporting laws are quite confusing across the country in a state-by-state basis. And in many times we're finding that healthcare providers, when faced with that confusion, are just reporting everything, sort of when in doubt, report. And unfortunately, we've really heard from survivors that that many times that reporting is not helpful to them. Again, the hotline survey found that the majority of participants felt that the reporting made the situation worse or had no impact. And over half, I should say, reported that it made the situation much worse. So that's a significant concern for us. And you see some of the quotes here, particularly upsetting, was that the police and CPS did nothing and the abuser went on a rampage against us. Next slide, please. So what does that mean for the work we're trying to do together? And how can we still capture this meaningful data on intimate partner violence? So with that, I wanted to share, I think for your considerations, a different approach that we've been working on in the field that I mentioned last time we spoke. It's a CUES approach, and that Q stands for confidentiality, universal education, and support. And it's a full intervention, but I'm mostly going to talk about the first part today. But I wanted to lift up that this is an intervention that's been implemented in community health centers across the country. It's been endorsed by the Department of Health and Human Services Family Violence Prevention and Services Program. HRSA and also supported its inclusion in their Intimate Partner Violence Health Partners Toolkit for community health centers. And HRSA has also been testing elements of this in their Home Visitation Learning Collaborative coin. So, and I'll share a little bit about the effectiveness in the studies as well. So I would say that it's widely disseminated. Next slide, please. And I just lifted up what the acronym stands for. And I'm not going to go into much depth just by lack of time around confidentiality and support piece, but just noticing and lifting up that having a universal education approach gives us an opportunity to normalize the conversations around intimate partner violence, and also offer information for those who choose not to disclose, or for those who are not experiencing intimate partner violence. And so if we're looking at those earlier studies, so those 80% of female survivors who might say who are survivors, but they don't let their healthcare provider know, they would not be receiving any information about the resources that are available in the community. So within a universal education approach, we have that opportunity to share the information with them, regardless of disclosure. Next slide, please. So what that looks like is sort of a two-part screen or messaging. And the first part, I will take the time to just read it. So many patients that I see are in relationships that don't feel safe, where there may be physical, sexual, emotional abuse, and fear. Because of this, I'm offering all my patients information about relationships and how they affect their health, for yourself or for you to share with friends or family members. If this is part of your experience, I want to make sure you have the help you need, or you can share it with a friend or family member if they ever need it. So that framing opens up the door for that information, offers a resource so people can take it with them regardless of disclosure. And then the follow-up is as straightforward as, has anything happened like this happened to you? Many of the programs that we're working with also say, is any of this part of your story? So those are the two ways of framing the follow-up question or question. Next slide, please. And then with somebody who says no, again, I'm glad to hear that. If anything should change, you can always come and talk to me. And then offering the resource and inviting people to share that with friends or family members who may need help. And it's this piece around altruism and peer-to-peer education that we have found has been particularly meaningful for both the patients and providers, so that everybody gets the resource if they feel safe enough to take it. Next slide, please. And this, you need to enter a couple of times. Thank you. And so we're finding, one more enter, please, that particularly during the pandemic, but across the board, it's this altruism that has been not only helpful for getting the word out and seeing our patients as sort of public health partners in prevention, but also by helping, we've heard that so many survivors report that they also are coping better and that they're benefiting from offering support to their friends and family members. Next slide, please. Even with this universal education approach, we do find that folks do disclose. And in fact, we found an increase in disclosures with a universal education approach. So again, this would be an opportunity to offer supportive messages, to thank the patient for sharing that critical information, and to offer that I'm sorry this has happened to you, and I really appreciate you telling me. I'm going to ask a few other follow-up questions just so I can understand your situation better and provide better care. And at that point, one could transition to additional assessments and care planning. Next slide, please. I mentioned that we are seeing some increased disclosure with universal education, and in one of our studies in adolescent health settings, we saw a 2.8-fold increase in disclosure with a brief intervention. And when you really open up the conversation in the way in which the intervention, if it was delivered as intended, then we saw a 9-fold increase in disclosure compared to participants who got care in the usual way. Next slide, please. So I mentioned it's an opportunity then to segue into further health assessments. I'm not going to get into this today, but I do think there's a real critical opportunity to address how somebody in an abusive relationship, how that partner might be interfering with their health care and their care plan. And there are a whole host of other assessment questions that get at partner interference and the impact it has on survivors, which we could talk about at a different time. Next slide, please. So I just lifted up the one piece around universal education, but I open it up to just allow us to have an opportunity to reflect on the limitations of screening, and in particularly when it comes to intimate partner violence, and particularly when we're looking at populations that might be more likely to be system involved or more likely to suffer disproportionate impact of police brutality or increased reports to CPS, so that we can think about maybe a new way to create standardized approaches to universal education, reaching those that don't disclose, and even reaching those who may not be survivors, but who can have an opportunity to share the information with their friends and family. So this is our website. You can get a whole host of other resources there, and we could maybe talk at a different time. Next slide, please, about those next steps. Yes, that's it. Thank you so much.
Lisa, thank you so much. There's a particular, first of all, I really appreciate the grounding in the correct way, well, at least the most inclusive way to do this work, and we're very grateful to integrate the CUES approach into our work at the Gravity Project. I do want to elevate Tom's question because it's on privacy, which is so much here. So Tom is asking, do you have any recommendations on data security related to IPV data? So I'm sure Lisa has like all kinds of thoughts. She really is an area of expertise of hers. Again, we just have a couple minutes, but I'm hoping you can touch on that. And then specifically, we can maybe, again, we have a bunch more meetings over the course of the next time. We can talk about that again.
Yes. Yeah, I will just say that would definitely be a much longer conversation, but we do have recommendations, both a series of privacy principles around documentation and data collection around IPV, currently expanding that due to the Cures Act, and also applying some of those principles to some of the care coordination platforms that are becoming more and more prevalent. So lots to say around making sure that intimate partner violence be considered sensitive information, and also different strategies to make sure that the patient has as much control as possible over the data and what gets documented in the record. So perhaps we can set up
Thank
a
you.
different time to talk about that.
Yeah, we actually have one of our elder abuse experts here. So Ron, do you want to just unmute and speak to what you're talking about regarding the break the glass note setting, especially in
Okay.
Hi.
Hi. Sure. I'm also a clinic director. Most EMRs and I'm sort of interpersonal violence writ large and elder abuse as a specialty. But in our clinic and in the Crime Victims Center in Charleston, South Carolina, Epic and other systems do have protection settings. And unfortunately, most of the time, the provider in the note has to add that level of security, and they're not infallible. They do create a trail, and they do require additional permissions to access the notes. And they're typically called break the glass settings. And then there's even higher level that you can do in some psychological, psychiatric note settings. But that's a brilliant point. And it's very scary to hear the data on people not reporting because they thought it might be disclosed. And those are real fears. We've had people posing as family members and things like that, and it was defense attorneys for rape perpetrators, and they wanted to get the psych notes, which so it's not just domestic violence. There's a lot of fear of disclosure that have real consequences that if we're going to try and encourage people to disclose, we need to address. That was a great talk.
Thank you.
And I do want to, sorry, Lisa, I just want to make sure that Lisa, elevate the fact that the wisdom of Lisa and Ron and our Fenway folks, we hope to carry into our technical build too, right? So Lisa's here for the long haul, and she's very, very interested in ensuring that those privacy considerations and safety considerations are carried through. And then Lisa, please close us out.
Sure. I was just going to acknowledge that, yes, I think that we have the capabilities. It's just about making sure that people implement them across the board. And even so, it's not going to be a perfect system, which is why the confidentiality and disclosing any limits, it might mean that somebody chooses not to disclose, is so important. So I didn't get into the C part of cues because we only had 10 minutes, but how to disclose those limits of confidentiality is a really critical component too. And then of course, down the line around how you document and code. So thanks so much for the opportunity to share some of those experiences from the field, and look forward to our partnership.
So lucky.
So Mr. Bob, yeah, let me just make a comment. We do have the ability in virtually all of the implementations to treat data as specially protected in a particular way, much like we treat 42 CFR Part 2 data, which requires the patient's absolute permission to go and release it and obligates the recipient to, again, require permission to re-release it. So we do have the technology capability and the ability to take data. The real problem, as you had noted, is getting providers to go and take it properly up front. That's a critical challenge.
Yes, and what gets put in the record and what gets sent home in the EHB. So anyway, I know we have a lot of other information to cover, but it's definitely, we do have some tools and recommendations, and there's a lot of education to the field, as you say, that's needed.
And Gravity is so lucky for everyone's wisdom. So thank you, Chris and Lauren from Fenway. Thank you, Lisa. Thank you, Ron, for piping in. He's coming back in a few minutes to talk about very similar limitations in elder abuse screening. So very, very grateful. And Bob, yes, thank you. This is part of the wonder, is that we get to marry these understandings of privacy and consent that are already in the ecosystem to address these critical needs. All right, so now a brief segue. My God, that today is literally just action-packed. We're so much to cover. Quickly segueing, just a brief update regarding social isolation orientation. Again, sorry that we have to move quickly through these slides. Again, just want to say thank you to our social isolation subject matter experts. Edward Garcia, Dr. Julianne Holt-Lundstedt, and Dr. Matt Pentel is here from UCSF today. Next slide, please. We really just wanted to elevate a specific consideration, because as you all see the data blooming in the data sets over the course of the released masters, you're going to see kind of a new theme in the way we're sorting data, both across social isolation, loneliness, and lack of social support, and some of our other domains. And that is really sorting it into screening tools and diagnoses with different subtypes. So there's also some refinement because some of the screening tools that we've been identified purport to screen for social isolation, but in fact, they actually are more applicable to loneliness. We'll cover more on that in a few bits, but we really are just trying to sort the information. So this is a screening tool for this. These are the diagnoses that will come out of it. So almost mini sets within our greater set, akin to how we did it with housing instability and homelessness, but a little bit more specific. And the next slide, Dr. Matt Pentel is going to speak very briefly on helping the community understand the difference between social isolation, loneliness, and social support, so that when you see these concepts on the master, you can understand where they are in place and time and what they mean and how the screening tools lead to these diagnoses. So Matt, are you with us?
Yeah, thanks, Sarah. Yeah, happy to go over these, which are understandably can be quite confusing because of a lot of the overlap that occurs with them. But in general, social isolation is thought to be, we have sort of two definitions we've been talking about up there. It occurs when an individual does not have adequate opportunities to interact with others, and it's an objective measure. Or another one is occurs when an individual infrequently interacts with others. And the real key here with social isolation is that it's objective. It's sort of, do you talk to people on the phone? Not do you have a partner or not? Is it something that you can quantify or dichotomize as occurring? Whereas loneliness is more of a subjective experience stemming from the perception of not having enough social relationships or contact with other people. So with this, it's really based on the perception of the individual themselves and how they are feeling in terms of whether they're feeling lonely or not. So you could interact with people, you could have a partner, live with your children, be a part of a lot of clubs, and talking to people every day, and you could still feel lonely. Alternatively, you could be very socially isolated. You could be not living with a partner. You have no, you don't participate in groups or interact with people, but you actually don't feel lonely. And so, really, again, social isolation is the objective measure. Loneliness is the subjective measure, and then social support adds in sort of the actual or perceived availability of resources from others. And this has been categorized as 4 types of behaviors: emotional, instrumental, informational, or appraisal support. So for example, emotional support would be expressions of empathy someone gives you. Instrumental would be tangible aid people give to you. Informational is advice that they suggest to you. And appraisal is information that's useful for self-evaluation. Now, the sort of difference between this and the other concepts is, let's say that you have a lot of interactions with somebody. You're talking with somebody every day, and so technically you're not socially isolated. You're speaking to people, but let's say every time you talk to them, it is not supportive. You feel that they upset you. It's not a positive interaction. So you're not socially isolated, but you're not getting social support. Whereas if you're talking to somebody and they're actually offering things that are supportive to you, that would be considered social support. So some nuances there, but thanks, Sarah, for the opportunity to talk about them on the slide, because they are some overlapping in terms of experiences, but they are actually different concepts.
Thank you, Matt. Actually, I just want to specify that we can very clearly see as clinicians in the ground level, or care management, case management, social work, how each of these different topics might require different interventions depending on the individual at hand. So over the course of the data set, you'll see again what the subject matter experts have identified as screening questions and answers that are really applicable to the different end diagnoses, so there can be a pathway through to them. And again, we're going to see a lot of screening tools that were identified as social isolation tools that are really actually more loneliness tools, because it's about the feelings. So this was a huge conversation with the subject matter experts on our last call. So there might be a little bit of work with the ecosystem to really ensure that we're aligning with this, just to ensure everyone understands outputs. Any other thoughts? Again, this was just a quick highlight in a sea of other really, really important information. Matt, thank you for coming in and joining the call.
Yeah, of course. Happy to. And I just put my email in the chat too, if people have questions as they're going through or reviewing, or just in general.
Great. And I just want to say, all hail UCSF, I swear. Like UCSF, from UCSF Siren, from our Eric Prather, our last stress expert. We have lots of friends from UCSF, so thanks for coming and joining us. Any other questions regarding this update? And why it's probably obvious why we felt it was critical to let you all know this before we enter, before you review the master list.
Sarah, just have a comment. This is Charles.
Oh, sorry, we have two different thoughts here.
Go ahead, Charles.
Oh, thank you. I want to comment on the social isolation. There is definitely a correlation between a rural area and social isolation, and also the prevalence of suicide as well. So I just want to point this out as well. Maybe there's some stuff that we can connect down the road. Over.
Yes, there is a lot. We have been talking about the rural. I mean, I have the honor of being a rural provider, so we definitely do try, just as we did with transportation, ensure that we include the rural perspective in our work. And then Monique, do you have something to elevate as well?
Yeah, I just wanted to ask whether social isolation is the infrequent opportunity to interact with others, which may be out of your control, like you may be very rural or you live alone in a rural area, or is it that your interactions with others are infrequent, which can be your own choice? So is it encompassing both of those, or is it really just addressing the first?
I'm gonna let Matt answer this one.
Yeah, that's a great question. I think, and different people have defined it differently, but in general, in my experience and sort of the what the National Academies I think was leaning towards when they were trying to define this last year was I think you're right that it's because it can be a choice that technically it is the lack or infrequent. It's infrequent contact with people, even if it's available. That would be my impression, and so. Like I was saying before, there's somebody who they might live in the middle of the city and have access to all these opportunities, but chooses not to. So technically, they are socially isolated, even though they are choosing that, and even though they do have access to opportunities. Okay. So it might be something we can nuance more, but it's a great question.
And Monique,
thank you.
You can see that as with our past domains, we're trying to elevate some of the decisions that we're hashing out with definitions to the community. In order to really be transparent about these kinds of considerations of meaning. So you always are very good
Thank you.
highlighting those. That's why there's two bullets because we're working on two different things. Any other thoughts before we move on?
I'm seeing questions. Should I take a minute to answer the questions?
Yes, and then we do just need to move on. So, but
okay.
I think one more question sounds great.
Oh yeah, so limited social skills interrelate with these concepts. So that can be a risk factor, if you will, for having social isolation or loneliness. But depending on, there are many etiologies to social isolation and loneliness. One of them might be limited social skills, and there are interventions to overcome those. But one of those one cause might actually be lack of hearing, and hearing aids might overcome it because then you can hear what people are saying, or it might be transportation because you can't drive by yourself. And then once you have that, so that I would say is one of the things that can contribute and that you would intervene upon if that was the cause. And then for loneliness, considered a risk factor for needing social support or an outcome in and of itself. So loneliness can be an outcome due to social isolation. Although again, some people are socially isolated and not lonely. Social support, gosh, that definition I think can get very messy. We talk forever. Usually it's just seen as the opposite of all of these sometimes. People who are, it has been defined as the opposite of sort of lonely, but we are trying to disentangle those and say that they are different concepts. And so you could say that loneliness might be a quote risk factor for needing social support if that would indeed overcome that barrier. And again, there's many etiologies to loneliness that happens. In terms of an outcome in itself, as I said before, it is in some studies looked at as an outcome when people have reduced social interaction.
I'm hoping, just to respect the rest of the presenters, that we can continue to have our subject matter experts present at the calls. They usually are here every time. So we do have another meeting in 2 weeks. And also, if you ever want to send questions or emails to us, you can send them and we'll forward them off to our SMEs. We meet regularly with our SMEs. And so we are very grateful that they can answer any kind of questions from the community as we go forward. Matt, thank you so much for coming. I just want to
Thanks for having me. Yeah.
Yes, I know. I'm respecting time. We do have Ron on the call to just kind of orient us to elder abuse before we get off the call, and I do want to respect his time, so we're going to keep on moving. Next slide, please. Next slide. And next slide. Right. So this is an old slide. So this is from the just talking about the adult maltreatment screening and assessment tool inventory. And the uniform definitions and recommended core data elements for elder abuse. Next slide. And next slide, please. I'm just trying to, it looks like these slides were not, okay, next slide. And next slide. And next slide. All right, so I'm just trying to get there. So it looks like some of the slides that I meant to take out didn't get taken out from the kickoff. So I really want to focus on this. And Dr. Rana Cierno's here to discuss. He was just on the, he unleashed himself to talk about the IPV safety elements as well. But we really are being asked to kind of hold ourselves to a higher standard with elder abuse than we've been held before. So as you know, with our past domains, there really were no gold standard tools for food insecurity. Food insecurity was the only one with the USDA food security module, and then for transportation, housing, everything else was under development. So with the prevalence of evidence really for elder abuse, we definitely are being asked to consider it differently. And so Ron is going to be here briefly to talk about something you're going to be seeing, which is behaviorally specific ways about asking about elder mistreatment and what the evidence shows about how that method is far superior to others when it comes to identifying episodes of elder abuse. So Ron, are you able to speak to that? And I do want to let everybody know that we did so this comes from a paper that Ron published, and the section of the paper that details the screening methodology is on the Confluence in the elder abuse section. So Ron, are you able to talk to this briefly?
Sure, and this builds on the interpersonal violence literature. Way back in the late 80s, Koss did a study where she used behaviorally specific questions of the legal definitions of rape among college students. And then at the end of that, she asked them, have you been raped? And 75% that had endorsed the legally specific definition said no, meaning the question, have you been raped, is not a good question because there's all sorts of stigma and cultural problems with it. For example, it's not rape if my family member does it, that's incest, or it's not rape if my boyfriend does it, that's domestic violence. But that sort of clued people into thinking maybe we shouldn't use, allusions. The Bureau of Justice Statistics used to ask about all sorts of felony crimes, robbery, physical assault, and then would say, is there anything else that you would like to tell me about? And that's how they determined sexual assault, which was, a great way not to determine sexual assault. And so as we were deciding how to best define elder abuse, we were also asking how should we ask about elder abuse? And the answer to both questions is probably with very behaviorally specific close-ended questions. Now, you heard another presenter talk about using an open-ended approach to broach the topic, but that only holds when you have a very skilled provider who's having that conversation. If you are trying to determine whether or not someone has had a specific event occur, it's best to be specific about the event that you're asking about. And so there's a variety of elder abuse screens. Sometimes the screens are for potential for abuse, and other times the screens are for the actual abuse event itself. Using behaviorally specific terminology allows you to ask very specific, what we call data elements, and then decide if you're going to call it abuse later on. There's a big problem in the field between abuse versus mistreatment. For example, abuse requires a care relationship. Mistreatment might be assault by a stranger. The person who's being punched in the face doesn't really care about that distinction. And the outcomes are also sort of blurred, meaning both those types of things. If a care provider punches you or if a stranger punches you, they're both bad. One might be worse, but it's very important to know about both in the same person. When you ask a behaviorally specific question, has someone ever hit you with their hand with the intent to seriously injure or kill you, hit or kick you? And then a follow-up, has anyone ever hit you with a stick, knife, or some other weapon with the intent? Then you have a very specific event, yes or no, this happened. And then you can ask, well, who did it? That way you can determine perpetrator status and when did it happen? You know, that way you can determine recency, or if it happened since they were age 60. The point is, when you ask very general questions or screening questions that aren't behaviorally specific, you don't get the same level of response. And this has been shown very powerfully and very clearly in the younger adult interpersonal violence literature. Yeah, there is actually, Scott Beach did a study. Someone asked the question, are there different ways of asking the question? The absolute best way is to, it's not interview, because the person is, there's cultural and stigma attached to that. It's not in-person interview, and it's not telephone, which is a better way to do it, but it's not the best. The best way to do it, believe it or not, if you have unlimited time and resources, is to present the person with an iPad or a computer with headphones. The iPad or computer reads the question out loud and they answer the question. That is the most likely way. And the question is behaviorally specific. That's the most likely way to collect these data. Now, if the person thinks that there's any chance that there's mandatory disclosure, and for domestic violence, it varies state to state. For elder abuse, it also varies state to state. For example, in South Carolina, you don't automatically disclose elder abuse unless it's a vulnerable elder, not defined only by age. And if the person thinks you're going to disclose, again, you're not going to get that result. You heard that in the interpersonal violence literature review. So, but my point is, we really need to keep behavioral specificity at the heart of any screen we use, or else we're ignoring all the work that's been done in interpersonal violence literature that shows that when you start using culturally laden terms or emotionally laden terms like rape to describe a forced sex event, you'll get lower rates. And it's better to describe the forced sex event in very neutral terms. I don't know how much further you want me to go with that. I can bring all sorts of examples to bear, and we can get into the problem with the trust relationship or not. And
I would love, I think what I hope to have you do is actually come back at the next meeting and talk about that as well. But because again, the importance is that we should demonstrate to the community. And again, I love that we're all recognizing that there are these themes of what we've learned from IPV that Lisa presented in the Q's approach, right? The community will be seeing this behavioral specific ways about asking about elder mistreatment as being the anchor of the data set, right? And so any questions, because I think talking about the trust relationship might be helpful, but we also have a few more things to cover before we go.
Okay, and I should also point out one other thing. Everything I said is completely meaningless if you're talking about elder abuse against a person suffering from dementia, meaning someone else is reporting it and they can't report it themselves. So I'm talking about independent or community residing elder abuse, which is actually the majority, but we just don't know about it.
Ron, thank you so much. So suffice to say, elder abuse has presented the Gravity terminology team with a classic rapid learning in order to be able to meet our subject matter experts and their expertise and represent the complexity of the domain. So when you guys see the masters for the first time, you will see this behaviorally specific approach. And then just one more question before we go. So Linda's asking if there's any data on whether there's a difference between verbally asked questions versus paper or electronic formats.
Yeah, that's what I answered that question with respect to the computer administration. In person is the worst. Computer administrating, where it reads it out loud and you just click yes or no, is the best. And paper and pencil is probably just behind that, along with telephone.
Thank you so. And so hopefully this is a lot of information from our subject matter experts, but hopefully the clarity that you have from these presentations can help inform your review of the data sets as they come across your the Confluence pages over the course of the next days. You should be expecting information on those on Tuesday when we release the masters to the Confluence. Thank you so much, Ron. And I think a quick policy and tech update, I knew that terminology was going to take up the heft of the meeting, and I was correct. Next slide. Passing off to Mark.
Thanks, Sarah. So to keep it really short, this is just to show you, the Gravity community, how much people are appreciating your work. This is the letter from the Health IT Advisory Committee to the National Coordinator, Mickey Tripathi, lifting up the Gravity Social Determinant data class as a key recommendation to add into US CDI version 2. We expect to hear what ONC decides to do with their final release in July of 2021. Next slide. And just an opportunity, the Office of the National Coordinator is also inviting people to submit what they're calling succinct aspirational health interoperability outcome statements. This isn't due until July 30th. This is just so that ONC can hear from people across the country what they'd like to see with interoperability by 2030. The link there will take you to more background so that if you're interested in doing this. Back to you, Evelyn. Sarah, sorry.
Thank you for that brief policy update, Mark. And then we left no time at all for my esteemed Bob Dieterle, but I hope we can give you enough time to get some things across, and my apologies, friend.
Yep, that's okay, not a problem. Basically, we're on track for the end of July submission of the SDOH Fire IG to publication. Next slide, please. Oh, and let me do one more thing. On that slide, we are planning on having a social determinants of health track at the CMS Virtual Connect-a-thon, July 20th through the 22nd. Next slide, please. We did participate in the Connect-a-thon, the HL7 Connect-a-thon 27. This slide will be part of the deck. We tested our reference implementation guide. We had roughly 30 participants, including a number of organizations that are deeply involved with social determinants of health, including several of the communication platforms, as well as state and federal organizations. Next slide, please. This is the detail on the CMS Connect-a-thon. You have until July 1 to sign up. There is no charge. We encourage anyone that is interested in coming and testing applications against the reference implementation to do so. We're going to try to make this as much of a test-a-thon as anything. Next slide, please. And I believe that's the end. Sarah?
Wow, you really did a good job. We're going to finish on time. It's amazing. All right. Wow. So we have just spent an hour and a half together doing kind of probably it felt like you were, baptism by fire on some really critical concepts regarding our domains. These are our subject matter experts are with us. We are so grateful. They are the people that I'm honored to talk to every single week as we try to sort things in the background in order to get things present and tidy for you. So they'll be here when we meet again on the 10th. Again, if you have any questions, please let us know. You should see specifically, most importantly, some of the masters being completed in 2U, for social isolation, and IPV. And again, in social isolation, you're going to be seeing the sorting of those 3 types. Intimate partner violence, you're going to see again, just generalized screeners. I did want to highlight something that I forgot to elevate during Lisa's presentation that I thought of. We really, akin to other domains, we are differentiating between initial screeners and secondary screeners. So if a screening tool is just a tool for assessing severity with the existing known presence of a situation of intimate partner violence, and this carries off to elder abuse as well, it's not going to be in our initial set, but Gravity is committed to building these core secondary screeners as long as we understand how to properly use them. So we remember there were themes of the same thing, like for instance, like eligibility screeners, or the communication with the homeless management information system, or verification of qualifications for non-emergency medical transportation. So you will see only primary screeners being part of the set for IPV, and so when it comes forward, but there will be secondary screeners that we are going to